Next, can I invite Dr. Rakhi, who is additional professor at IGIMS, and she is actually the golden girl of Bihar. I would say she has won the best paper for cornea in AIOS, and she's a dynamic cornea surgeon. So, Dr. Rakhi.
Thank you so much for kind introduction. First of all, I would like to thank Pranam sir and AIO Scientific Committee for giving me this opportunity. So I'll be presenting a case of post-keratoplasty endophthalmitis. So this is a case of 61-year-old man who referred to us for second opinion. He presented to us with redness, pain and diminution of vision for 4 days, and he had a history of triple procedure which was done 9 days ago. So on this is the timeline of the patient. On the discharge summary, it was written that patient on the time of discharge, he had graph clarity 4 plus and visual acuity was 660, and at that time AC was formed and coiled. On day 5, he developed redness and pain, but he had taken no consultation at that time. On day 7, he consulted at the same center where he was operated, and at the time of visit, he had white infiltrate. It was mentioned on the card that it was a white infiltrate near in the superior temporal quadrant. The size was not there, and it was not written that epithelial defect was there or not. Hypopyon, streak hypopyon was mentioned, and B scan showed echoes in vitreous, and patient was planned for intravitreal antibiotics and topical treatment was started, but no intravitreal antibiotics were given at that time. So he was referred to us on day 9, and at that time on examination we found that there was graft edema of present, and graft clarity was 2 to 3 plus. The AC was filled with the hypopyon. It was up to around 5 to 6 millimeter. Corneal sensation was normal, and there was involvement of graft host junction in the superior temporal as well as in the inferior nasal quadrant of about 1 to 2 millimeter. Still epithelial defect was not there. So we planned for pars plana vitrectomy because cornea was clear at that time, and along with intravitreal injection. So retina consultation was done and patient was posted for intravitreal antibiotics with PPV. It was done, and sample, the AC tap and vitreous tap was sent for microbiological investigation, and we started the routine empirical therapy including vancomycin and ceftazidime along with cycloplegics. Steroids were stopped at that time. And after 48 hours, we got the report of culture which showed methicillin resistant Coagulase negative Staphylococcus, and that was sensitive to vancomycin, gentamicin, amikacin, and linezolid. So we continued the same therapy, and patient improvement was there. And after a month in follow-up, we saw that endophthalmitis was completely resolved, but the graph clarity came down to 2 plus, and there was a sign of graph failure. So in this case, 2 or 3 problematic points were there. Patient presented very late, 4 days late after onset of symptoms, and after appearance of this endophthalmitis, we could not trace the donor rim, and we could not get the culture of residual donor rim and the media, and because of the delayed presentation, we could start the management late. So there are some peculiarities of endophthalmitis following keratoplasty which make it different from the post-cataract endophthalmitis in terms of rate of incidence, risk factors, the microbial spectra, clinical picture, and management. So as far as incidence is concerned, its incidence is 0.08 to 0.77, which is showing some downtrend. And initially it was thought that rate of endophthalmitis after PK was more than endothelial keratoplasty, but nowadays there are literature showing that rate of endophthalmitis after EK is more than PK because of some additional step of donor corneal preparation, sometimes in eye bank and sometimes in OT with the prolonged time, and additional intraoperative manipulation. And also it gives a dead space for organism to grow. So what are the risk factors other than post cataract endophthalmitis cases? There are additional risk factor of donor tissue contamination. If we retrieve a donor tissue from a patient dying from any kind of infective disorder or he has a septicemia at the time of death, or if has a history of prolonged ICU stay, in these cases donor tissue contamination are very common. So we need to have a good sepsis at the time of retrieval and processing and during surgery. There are host factors also, like high risk indication in cases of microbial keratitis, in cases of wound dehiscence, corneal perforation. These are the cases which are at risk of developing endophthalmitis in post-operative phase. And other than that, the post-operative events like suture removal, wound dehiscence, vitreous and calcination, they make the patients at risk for endophthalmitis. In etiology, it's similar to the post-cataract endophthalmitis, but here, because donor-to-host transmissions are common, so gram-negative bacilli are very commonly found in these cases, and especially MDR. So unlike cataract, post-cataract endophthalmitis, here we get high culture positivity in post-keratoplasty patient, and with higher bacterial load, the organisms are probably of great virulence, and donor cornea is as a source of infection, and these patients uses steroid for a longer time. So this is a study from LVPI. They studied 28 eyes in 13 years, and they found that gram-negative bacilli are more prevalent in these cases, in contrary to the data from the Western countries that have quoted fungal organisms are more common. So as far as clinical picture is present, these patients can present within 6 weeks or more than 6 weeks. Both will have similar picture, graft edema, severe AC reaction, hypopyon, and loss of red glow. But here the important point is always try to differentiate acute graft rejection from endophthalmitis, because both of these entity will present same at the time of presentation. So it's very important to look the vitreous exudate on B scan and segregate these two entities, because they both have completely different management. In management and prevention, unlike post-cataract endophthalmitis, these patients, we have limited evidence to guide the initial management, and because of dense corneal edema and associated keratitis and corneal involvement, the view may be limited for any intravitreal procedures. And after even the best of efforts, we can have the graft failure in these cases. So overall management is same, like keratitis, corneal scraping or intravitreal injection, endophthalmectomy, or if possible removal of graft or IOL. So the preventive measurements are more important. At the time of retrieval, we should screen the donor properly for any evidence of infection. We should instill the povidone iodine for at least 3 minutes, and if possible, more potent antibiotics or antifungal should be incorporated into the corneal preservation media. So outcome, after the best effort, these patients usually may resolve after certain period of time, but the graft actually it gets failed, and patient's visual outcome is very poor. Anatomical restoration can be done with best efforts, but visual outcomes remains poor, and so these patients may require regrafting after certain period of time. So post-keratoplasty endophthalmitis is a rare complication associated with devastating visual loss and poor structural outcomes. So these patients always require a good follow-up for timely detection and management of endophthalmitis or any other event which is related to keratoplasty. Thank you so much.
Thank you, Dr. Rakhi. Just one question. Like, do you think the management, if it is a donor-related endophthalmitis and acute endophthalmitis, is the management going to be different? And which is more common? Is it the
there are studies like if you take the lamellar keratoplasty, you will find more common is donor-related infection, donor-to-host transmission. But in cases of PK, where we apply number of sutures and patient may get wound dehiscence, trauma, epithelial defect, poor ocular surface, in these cases, endophthalmitis, non-donor related is common. So in cases of donor to host transmission, we should always get to know that what is the organism present in the rim culture, so that we can get the sensitivity fast and we can work according to the reports. Because as a literature source and as we have seen in our scenario, that gram-negative bacilli are very common in donor to host, particularly Pseudomonas klebsiella, and they are very resistant to routine therapies. They are sensitive to colistin or imipenem. So we have to start these therapy in early stages to restore the integrity as well as the visual outcomes.
Thank you.
Yeah, very nice presentation, Dr. Rakhi. One thing, I just wanted to ask you how to differentiate between a graft rejection and endophthalmitis. Should we do a ultrasonography? Because if there is a graft rejection or
Pardon,
endophthalmitis,
sir? How to differentiate?
how to
Graft
differentiate between a graft rejection and endophthalmitis? So for that, should we do a ultrasonography in all cases? Because the corneal haze and edema in both the cases are going to mm, give us difficulty in visualizing the vitreous and the retina.
In donor to host transmission, you want to ask?
Yeah.
In these cases, usually infection starts from the graft host junction. And in normal cases, you can have hypopion or the decrease in the glow or decrease in the vision. But in these cases, donor to host transmission, there is multiple foci of infiltrates at the host graft host junction. And these are the clue that you can go for the culture and everything of the rim and media. That what was the organism and how to trace it and how to deal with those organisms.
Okay. Okay, right. So we'll